coming. I know lunchtime is a busy time. This is the first of a 6-part series on LIC faculty development that we'll be hosting across April, May, June, and July, and then these will all be available on the web. Today we'll be talking about maximizing the LIC Patient Panel for meaningful student, faculty, and patient experiences, and I'll be co-presenting today with Dr. Anne Frank, and we also have several of our LIC medical students who will be participating today with some feedback and ideas for their preceptors. Quickly, we don't have any disclosures for our team today. This is part of a CME series, and so you can get CME for participating in one or any of the sessions that are happening over the course of the spring. The CME claim will be through the CU CME office, and they'll be sending you a survey at the conclusion of all of the talks. So even if you just come to one, the claim ticket will come in July, and you can let them know which session you attended and the amount of CME that you'd like. Here's our agenda for today. We're going to be discussing LIC learning theory and the way that supports the concept of the LIC Patient Panel. We're going to be discussing the role of the Students Patient Panel in the LIC, and then identifying strategies to facilitate longitudinal patient experiences for our LIC students. I always start with this. My guess is most of our participants today are participating in an LIC in some capacity, but just to make sure we're all starting from common ground, let's go ahead and define what an LIC is. So this is CU's core clerkship model, and it is a preceptorship model in which students are participating in comprehensive care of patients over time, engaging in continuity relationships with preceptors, and they're meeting the core clinical competencies across multiple disciplines simultaneously. So all of their different core clerkships are interleavened and in dialogue with one another across the arc of the year. And we have ample evidence for LICs across many institutions and many countries and many decades at this point. We know that students who learn in the LIC model have equal or better performance on standardized exams, clinical assessments, sub-internships, national board examinations. And this is the one that always gets me, because this is the way I want to practice medicine and the kinds of colleagues that I want in the future. Students who participate in LICs actually have better performance on patient-centeredness scores and empathy as compared to classmates that have been in a block model. So then the question arises, how do we maximize learning in an LIC? And that's why you're here today as current LIC preceptors or future LIC preceptors. How do I do this well? How do we build the knowledge and skills that our medical students need? And how do we foster that patient-centeredness and that empathy gap? And I mean a positive gap based off of the LIC model. So when it comes to the patient-centeredness piece, we actually have data that came out of one of the flagship LICs at Harvard that measured students on a validated patient-centeredness score at the beginning of the LIC, and that's what you see over here on the left of this graph. And then they measured them again at the end. And so you can see that at the beginning, pre-clerkship, students who were in the LIC, which is the top bar there, and students who were in the block, did not have a statistically significant gap or change in their empathy and patient-centeredness. But by the end of the year, they did. And we actually know now, when they've tracked those students into their residency and on into their careers, that patient-centeredness endures over a decade after the LIC. So there's something magical that's happening in the LIC that's helping students develop patient-centeredness and empathy compared to the erosion that you actually see in students who are in the block model. And one of the theories is that is coming from the longitudinal patient care that is explored through the LIC Patient Panel. So we know from LIC learning theory that the big ways that we're optimizing those learning outcomes has to do with the knowledge integration across specialties, the longitudinal variability that the students get to see when they track patients over time, and then also this big piece, the continuity. And continuity then links to role. So as the students are increasingly having continuity with their preceptors and with their patients, we know that they get activated into a more active role as a clinician in those settings. So this is a key paper that came out of David Hirsch, who drives a lot of the LIC literature, called The Role of Role, Learning in Longitudinal, Integrated, and Traditional Block Clerkships. And this is one of the key quotes here. I'm just going to pause and read it. Although both LIC and block students report reported serving in important roles and supporting their patients and sharing information about their care, only LIC students consistently described opportunities to grow into a doctor role with their patients. The high level of integration of LIC students into care systems and their deeper relationships with preceptors and patients enhance their motivation and their feeling of competence to provide patient-centered care. Now, this doesn't happen automatically just because they're in the LIC. And so the question for us today is what we can do as LIC preceptors to really activate this role. And I'm going to argue for you that the LIC Patient Panel and how we support it as a preceptor is a big part of that. So what is the LIC Patient Panel? These are actually the expectations that we share with our students at CU, so that the students will have a minimum number of cohort patients in each specialty, and they're expected to follow these patients over time and across care venues. And we think of a longitudinal contact as at least 3 separate encounters across the arc of the year. We envision that the students are serving as advocates and navigators for their patients throughout the clerkship year by attending visits, admissions, procedures, a delivery with patients from their panel. And this is what their expectations look like. You can see that they do cross domains, but they're not explicitly linked to a given clinical setting. So when you look at that top one, 2 inpatient adults, this is not that a student is seeing the patient and rounding every day. And so therefore they meet that, requirement just by being on service. This requires some intentionality that the student has met a patient, maybe they met them on an ER shift, and then they follow to round on them in the hospital, and then they follow them across into discharge care and into primary care follow-up or specialty follow-up. So it expands the entire care spectrum there. This might be a patient actually that they're following in a primary care setting who's getting admitted. And so they follow them from the primary care setting to the hospital and back again. The surgical patients are a little bit more narrow, pre-surgical to operating room and then post-op care, as is obstetrics. But a lot of these other domains, a student could meet this patient in a variety of different settings. So a pediatric patient could be met in family practice or in ped setting or a hospitalization. A cancer patient could be met in the hospital or could be identified in a primary care setting, and so on. We encourage students to think about panel patients as individuals who are going to have a lot of touches on the healthcare system. So a healthy patient who comes in once a year that they meet for a wellness visit or a physical is maybe not the best patient for a longitudinal care patient because they need to have multiple contacts together. But patients who have engaged with a brand new diagnosis, they often have lots of touches, so to speak, on the healthcare system. Patients who are coming in frequently for chronic disease management. Patients who are at the beginning of their life or at the end of their life are often frequently circulating through our healthcare systems. Socially complex patients are another really wonderful candidate for students who are looking to engage with panel patients, particularly because they can step in and help with navigating the healthcare system or potentially help the patient as they advocate for themselves. Our students tell us that patients who are on the cusp of a big change, so for example, contemplative about losing weight or stopping smoking cigarettes, changing their patterns with alcohol, could often really be a great candidate for a panel patient because they enjoy the extra leaning in that the student provides as they check on them on their progress. And then we also really encourage students to really find some of the patients where their rapport just really hit it off, follow their heart, follow their curiosity, the places they might be headed in their career, and choose patients that are in those areas. The responsibilities of our LIC patients for their panel are to familiarize themselves with the patient's major medical issues and the psychosocial aspects of the patient's illness. We want the student to be that patient's expert wherever they are across the community, not just in the hospital. We expect them to be following up on the labs and studies and consultations and to be dialoguing with their preceptors about next steps, even if they're not necessarily there with you in clinic that day. We encourage them to be taking primary responsibility for communicating results to the patient, clearly in consultation with an attending or a preceptor, and to be taking primary responsibility to communicate with other members of the patient's care team, and then to really break out and get into consultations, procedures, hospitalizations, wherever possible. Finally, we encourage them to assume an active role when they learn that their patient has been admitted. This takes a lot of extra effort from the students. So we really encourage them to plan what I call wraparound time. So they may need to be getting to clinics early and considering staying later if they're going to be following up on things that happened when they're not there. So if you're in the LIC structure right now, you know that the students are in a lot of different places across the week. This is a classic LIC schedule on the bottom. I'm a preceptor in internal medicine clinic, so I would be the purple box there. And so the students with me every Monday morning. And so if they're going to be following up on things that happened with my patient, they need a communication strategy for how they're going to be in touch with me across the rest of the week, hearing about things that happened with that LIC panel patient, and also how they're going to be following up with the patient about things. So I encourage them to be thinking really intentionally and planning strategies with their preceptors around this. And then where does this happen? Gosh, this can happen anywhere. And I think this is really one of the things that is a challenge for us to think about at the beginning, but then becomes really rewarding the longer you're working with students about their panel patients. So there is some serendipity that can happen here. Certainly, students can see your patient again and again and again, just in your setting. We also encourage them to think about other ways that they can engage with the clinic or with a patient within your setting. So are there other care team members that they could do a warm handoff with, or even stay? We've had preceptors and students tell us examples of, I started with my primary care doc, but then we needed to hand off to behavioral health. So I stayed with the patient. I stayed with the patient when they went to the pharmacist. I stayed with the patient when they went to do their insulin teaching with the nurse rather than handing off. And so continuity can happen even deeply within a primary care home. But it also includes following patients from primary care to specialty care, or from specialty care back to primary care. And then the ways that we can follow or have our students follow patients in and out of urgent care settings, procedures. We've had students go and keep their LIC patients company while they were getting infusion therapies, chemotherapies, and then even following them into the OR or for home visits. We're going to pause and pivot now. In fact, I'm even going to take us out of the screen share. We have 3 students here who are at different stages of their training who've participated in LICs. And Dr. Frank is going to walk you through hearing their stories and thinking about the ways that their preceptors were helping them foster continuity with their LIC patients, because it does require some investment and action from both the student and the preceptor.
Hi, everybody. Thank you all for being here. I'd love to start with the students just introducing themselves, letting us all know when and where they did their LIC time. And perhaps if you know where you're headed specialty-wise, go ahead and share that. And Matt, since I see you first on my screen, maybe you can start.
Yeah, totally. Hi, everyone. I'm Matt. I am a 4th year medical student, just about to graduate. I'm going to Brown University in Rhode Island to specialize in internal medicine. I'm very excited about that. And I did my LIC down in Colorado Springs a year ago, I guess. Feels like a lot longer ago, but it wasn't.
I'll have you hand off to Nikita.
Hi, everyone. My name is Nikita. I am a current 3rd year starting my AI next week. I am interested in hospital medicine through IM, and then I did my LIC at Denver Health.
And Alyssa.
Yeah, hi, my name is Alyssa. I am a current 2nd year, so I'm in the thick of the LIC right now down in Colorado Springs. And right now, I think I want to do pediatrics or pediatric psychiatry.
Wonderful. Thank you all. First, tell us about an impactful longitudinal patient relationship that you have developed or are developing during your LIC.
Okay.
Okay.
No, go ahead, Nikita.
For me, one of the ones that I had that was really impactful, especially in the context of wanting to go into hospital medicine and knowing that transitions of care is really important, was having a longitudinal patient from my inpatient rotation that I took care of through admit to discharge, and then being able to go to her first initial follow-up appointment from the hospital It was both like a PCP follow-up as well as a behavioral health follow-up. She was a patient with alcohol use disorder, and it was really nice to, one, be able to act on the things that I actually wrote about on a discharge summary and be like, okay, I remember this because I wrote it, and be able to carry those out in her first follow-up appointment, as well as kind of learning more about her and her behavioral health appointment, and kind of seeing to like how she got to the hospital, how she got to the point where she was drinking so much that she now has liver failure, and really being able to understand her more. And also just feel like patients always look a little sicker in the hospital. And once they're in kind of their normal people clothes, it's really great to see that as well, just to see her in a different setting and doing so much better from when I first met her.
That's a great story. I'm glad you had that impact too. One of my impactful patients I met in my outpatient internal medicine clinic actually was Dr. Cassidy, who was my preceptor. And this patient came in with a complaint of abnormal uterine bleeding. And after, initial workup and talking through things, it really unfolded that this patient was we are unfolding that she had a new diagnosis of cirrhosis, and it was alcohol-related cirrhosis. And so I had the opportunity as a medical student, with the extra time on my hands, to sit down and really talk with her, and kind of elicit what was going on and kind of a game plan to cut back or stop drinking. And we had the unique possibility at this clinic too. It was at the Army hospital, so everything's in the same building. And we had the opportunity to go and just drop in to GI clinic upstairs for a consult with GI. And so quickly my role changed from her primary medical student provider in my internal medicine clinic, and now I became her patient advocate one, a learner also, learning what happens in GI clinic, but I also had the opportunity to start practicing handoff, which isn't something that we really get to do a lot. And so I got to give a handoff to this GI specialist, and then sit in the room both as her advocate and just listen to what that perspective of medicine looked like. Then between the GI clinic and when she went home, I then started following up with this patient via phone call, which was also a new thing that I hadn't really practiced before. And so rather than, a formal visit, Dr. Cassidy encouraged me to just call this patient and just chat. How are things going? Are you staying away from alcohol? What things can we do to support you? Kind of in an informal setting, which was a new, unique aspect of healthcare that I was excited to try. And then my LIC was built where I was doing my obstetric gynecology rotation up in Canyon City, which is actually where the patient lived. And we were able to actually set her up with my preceptor. And so one morning I walked in and I was like, oh my gosh, that patient's on the list. And she was getting followed up for her abnormal uterine bleeding. And I looked at my preceptor and I was like, I know this patient. And I had this cool role where I filled her in. And I was like, this is the internal medicine perspective. This is what we're working up down in the Colorado Springs. And now let's bring it into this obstetric lens. And the MA roomed this patient, and the MA was like, yeah, there's a medical student here. Is it okay if this med student comes in? And she's like, no, I don't want a med student. And the MA walks out and she's like, yeah, no med students. And I'm like, wait, did you tell her who I am? Like, hey, just tell her it's Matt. The MA's like, okay, sure. Walk back in the room. She's like, oh, it's Matt. And I hear from behind the closed door, she's like, oh my gosh, Dr. Matt, of course he can come in. And that was like the coolest thing for me. Just one, being called Dr. Matt. Imposter syndrome skyrocketed. I was like, I'm not a doctor. But it kind of showed how much of an impact just being like, one, her advocate, but also just that continuity of someone she'd been seeing throughout this new illness was really, really special.
Wow, that's cool. So for me, I have a pediatric patient right now who I'm currently following. She's a 9-month-old that was born with fibular hemimelia. So she was basically born without a fibula, and because of that has had a lot of leg length discrepancies, a lot of joint instability, and we're also kind of monitoring her weight. She's having a little bit of failure to thrive. And I met this family right after they'd had an orthopedic consultation in which they were told they were probably going to have to do a below knee amputation on this little baby. And they were not ready to do that. They hadn't even really processed this diagnosis, let alone, a big surgery like that. So it was a really emotionally difficult visit kind of from day one. But what has been really cool is I've gotten the opportunity to follow them to various orthopedic specialists. I'm in Colorado Springs right now, but I actually came all the way to Denver for a visit for them. And what was really great about that was I was able to then communicate with my preceptor right away, kind of how that visit went, what the family was thinking, and then we could put in a referral for PM&R, for example, right away without having to wait for them to come back to clinic. And this family is also Spanish speaking, so they already, I feel like, face a lot of barriers in terms of communication from a lot of the things I've heard from them too. So just kind of another layer to remove. And whenever there was maybe confusion at these other appointments, I was able to kind of fill in and explain what's been going on, which has been really cool. It's really hard to feel useful as a medical student sometimes, but I really have felt like a part of her care team. And now, I go to all of her weight checks. And when I'm at the peds clinic, the care coordination team, they'll ask me questions before even my preceptor now, because I know their social situation really well and can say, oh yeah, mom is not going to answer her phone. You have to call dad. This is when he gets off of work usually, I just know those details about their life, which has been really special. So while this case has been really medically interesting, I also feel like I've had a really cool opportunity to see what it's like to get, a diagnosis like this and how our families processing it. What kind of tools and supports do they need?
Thank you all for sharing those stories. And there's so many pearls of wisdom that you bring just within each story. I wonder, what did your preceptors do in this instance or other instances to foster continuity with panel patients?
I can jump in. So I owe my whole thing to my preceptor. I'm lucky enough to have someone that actually went through this LIC model herself. So she really gets it and has been kind of looking out for panel patients for me from the beginning. In this family, I was not scheduled to be in clinic this day, but she knew that this was going to be a really interesting and meaningful case. So I actually went in on one of my extended learning days to go meet this family. And what was really beneficial for me and something that I've carried into my other panel experiences is sometimes it's kind of hard to introduce the idea of a panel patient to patients, at least for me, to be like, hey, do you mind if I follow you around? But she was able to phrase it to the family in a way that's like, hey, I have this medical student that I really trust, and she can go with you to these appointments and be your advocate and communicate with me, make sure we're all on the same team, and the same page. And they had full buy-in kind of from that moment. So that was really helpful to get that backing from my preceptor. And then since then, she's been a really active part of it too. Every time I see her, we talk about this patient. If this patient has an appointment that I can't go to, my preceptor already will have the notes pulled up and we review it together. So it's been really nice to feel like it's not just a me thing that I have to do for school, but we've been a big team together.
I'd second that, kind of having the preceptor back you up and really be the advocate for what you're doing, because it is a unique thing, especially for the LIC. Normally, going to the doctor, they're not expecting a medical student to follow them to their next appointment, but framing it in the sense of they're your advocate, they're here to learn, they're here to support you. It can be a really cool catalyst to getting panel patients. Another thing that I thought was really useful and really helped kind of explore different means of how we follow our patients was using the inbox function. And so in those weeks when I wasn't, I had internal medicine clinic on Thursday morning. And so from Thursday morning until next Thursday morning, I didn't have access to the EMR, but labs come in all the time. And so using my preceptor would send me, Dr. Cassidy would send me labs and image results to my inbox. So then I would arrive early on Thursday morning and review those and be able to just kind of feel like I'm keeping up on the things that I'm ordering. And, those things that I'm ordering have results. And now I'm feeling like I'm playing a part in actually working up disease and illness.
Yeah, I would agree with, both the other panelists. My preceptors were really helpful in identifying patients that would be good for me to follow, like if they have like a complex disease course or they see a lot of specialties, they'll be like, we think you should just like see them, even if the care is really complicated and you might not be able to make much of it in that particular appointment. It'd be over time be a good learning experience and a good patient to follow into different contexts. I would say especially my EM preceptor, being able to follow patients from the emergency room into inpatient because she knew that I was interested in hospital medicine, kind of identifying, okay, which patients do I think are going to probably be admitted tonight or tomorrow? And maybe you can follow them into the hospital and have that continuity of care. That was really useful, as well as my peds preceptor. I remember when I first met him, he was like, we're going to find you a baby to follow because they come in every month and they have incredible change in such a short amount of time. And also you just get to kind of be with the family through these like first initial months of a newborn child's life, which was really special. And he would always try to kind of make follow-up appointments for kids who did need them on the day that for peds, it was like the same day every week, like making sure they were coming in on that day so that I would be able to see them again. And then kind of what Matthew was talking about as well, my preceptors were really good about forwarding me lab results. I have tabs as well, but eventually you add so many patients on Epic that you're getting like 50 lab results every couple days. So having those pointed out to my preceptor and be like, hey, did you see the lab results? What do you want to do? Kind of communicate back and forth with your preceptor about the plan. And then I would actually go into the chart, pen the orders. My preceptor would sign them and I would get to call the patient and be like, this is what your lab results say. Are you okay with this plan going forward? And things like that. So the preceptors definitely played a huge role in like me being involved in as a meaningful part of the care team, as well as identifying good patients to follow.
Thank you all. And because these points were so excellent, I'm just going to kind of summarize. So it sounds like preceptors both identified patients, kind of going back to Heather's slide, kind of meeting those characteristics of which patients would be good patients for students to follow. They facilitated follow-up on the same clinic day. They introduced you all as like the most valuable members of the team, or very valuable members of the team who they trust. They then kind of communicated with you between visits or between times when you were in clinic with them to help facilitate continuity and have you create ownership with the patient. So I just really appreciate all of those excellent points that you brought up. And then many of you alluded to some things when you told your story, but I'd love to kind of point out, or have you all point out what you did to find opportunities for continuity with your patients. How did you kind of manipulate your schedule or sort of find those opportunities for patient continuity?
One of the easiest things that I would do is really just ask permission of the patient, especially in my outpatient clinics, say, I want to follow up in 4 weeks. In 4 weeks, I'm here on this Thursday morning. You have flexibility in your schedule to schedule you that Thursday morning. And so it's almost, and I see it here scheduled proactively like thinking, oh, I'm here on Thursday mornings in 1 month. Let's try and get you in clinic so I can set up another follow-up with you. And I found that to be a really quick and relatively easy way to really build a panel, at least an outpatient clinic. On the contrary, on the inpatient side, I would then kind of help follow my patients is really utilize the list function in Epic, at least in the places that used Epic. Add every patient that I saw to like my patient list. And then about once a week or so, I would get on and just, run the list and just see if any of my patients were admitted. And if they were, go in and see them just as an advocate. And it wasn't necessarily going and writing a note. I did that once, but it was more so going in, checking on how they're doing. And then sometimes those patients were also patients that I was seeing in outpatient clinic. And so then I'd be able to communicate that to my preceptor. Hey, I went and saw this patient in the hospital. They're admitted because of this. This is what they're doing. And hopefully we can follow up with them on a day that I'm in clinic when they come out for hospital follow-up.
Yeah, I did a similar thing as Matthew, like running I basically just added like almost all my inpatient patients I added. And then for outpatient ones that I saw got a lot of specialty care outside, or like when you first click in their chart and you're seeing like a bunch of encounters coming up, just knowing that they have frequent contact with our healthcare system. I mentioned this previously before. I thought that PEDS patients, especially on the younger side, were really good cohort patients just because they had a lot of appointments that were mandatory for their parents to take them to. And then I really tried to focus on the inpatient side because I was really interested in being at their follow-up visits if possible, if like our schedules allowed. So I think those were all good sources of how I found cohort patients, just kind of casting a broad net and like narrowing down, but also looking for patients that tend to have higher contact with our healthcare system. Because, there's a lot of patients that I did add that I would have loved to seen again that just never came up within the year that I was working there again.
Yeah, I mean, I agree with everything that's been said so far. I don't have too much to add, other than like Dr. Cassidy alluded to earlier, there's been a lot of instances, especially in like my PEDS clinic, where I will stay if I know that the care coordination team or behavioral health is going to meet with that patient. I'll stay and be a part of that. And then with some of these panel patients, like this little 9-month-old that I've been talking about, sometimes like they're going to have visits that don't fit into my schedule. And there's been a couple of instances where I've communicated with my other preceptors and actually just switched my clinic times, or made some flexibility so that I could go to those appointments, because I do think that the continuity is really important. And the patients always really appreciate it. When I say I'm going to be at their appointments, then I am. And so far, all my preceptors have been more than willing to be flexible with me so that I can make those appointments work.
And I'd add that this also, like it worked for some of the clinics that I didn't foresee at the beginning, really like working for panel patients. I rotated through surgical oncology for my first half of my surgery rotation. And in surgical oncology, a lot of those patients are also paired with medical oncology. And I found that actually just walking into the patient room, rather than looking through the chart and just showing up, I would ask the patient, hey, who are you seeing for medical oncology? Would you mind if I joined you at this visit? And if it fell outside of the time that was blocked for my surgery rotation, I found that the LIC was pretty flexible on moving shifts. So I could talk to my outpatient pediatric preceptor and say, hey, can I come in on Wednesday this week instead of Thursday so I can make this medical oncology visit with a patient I'm following in surgery? And so there was a nice flexibility with the schedule, but also flexibility within each specialty and how you could follow and really build a robust panel of patients with all sorts of disease.
Mm-hmm. I think on that note too, some patients do have really frequent contact with the healthcare system, and it might not be possible for you to make every single appointment, even if you would like to. And like, especially in the cases of where you can move around the schedule, sometimes if I saw an appointment that I thought was going to be, really impactful for the patient and really important to go to, I would kind of move my schedule around to make that, versus if it's like, this is their kind of every 2-3 week PCP checkup that I've been to like 2 or 3 times, like maybe it would be better if I go to the specialist appointment that they've been waiting for like 4 or 5 months. So kind of picking and choosing there, unfortunately, about which ones you think you're going to be able to make the most impact, are going to be most impactful for your patient. And then, we can't move around our schedules indefinitely. So kind of picking and choosing where it's appropriate to do that.
I love that you guys are all speaking about ways that you explored the flexibility in your schedule. So for the preceptors who are here listening today, the students all have what we call extended learning time scheduled into their week. And so it's essentially flex time. We expect that they're doing something to advance their clinical learning during that time. And that's what allows us to be able to move some things around so that they can follow these patients across healthcare systems, across specialties, and really follow them across the arc of the year. So those stories, I love this part of our talk every time because I learn new things, and I also feel like it really brings the patient panel concept alive. And one of the questions that often comes up is, well, what about the patients? It seems like this is a really great thing for our students. And I think that Matt and Nikita and Alyssa all showed some ways that this was probably beneficial for their patients as well. But we do actually have a body of medical education literature that's emerging that confirms that this seems to be a really positive thing for patients. So one of the key studies actually came out of Denver Health, with Dr. Adams being the senior author of that, and Robbie Flick, who was a LIC student at the Denver Health LIC, was the first author there. And they explored the patient experience. So they took a look at the names and identities of that the students submitted of people that they had followed, and they reached out to people who had had 3 or more contacts with the student and invited them to come in and be a part of a focus group and discuss. And what came out of that is that the patients who participated in these 3 or more kind of long or longitudinal patient experiences valued the therapeutic alliance that they had developed with their LIC students. And they voiced an improved sense of experience, patient experience, and that they felt like being a part of the relationship with the medical student really helped mitigate some of the other negative experiences that they had had in the healthcare system. While this study was not looking at hard outcomes like A1Cs or blood pressure metrics, the patients reported a sense of improved health outcomes related to their experience with LIC students. And they also discussed a sense of loss when the student was transitioning, or a sense of sadness that the student was moving on. They proposed a model that looked like this in the article. So on the far left here, the start of the relationship, role clarity, which each of our students spoke a little bit about, like my role here is as navigator, as mitigator, as communicating results back to your as your PCP, and also the way that the attendings were and preceptors were facilitating that role clarity for the student and for the patient. And that really was the launch of the relationship. And then longitudinally over the arc of the year, there was a manifestation of caring and a growth of trust, where the patient was really coming to trust the LIC student. And that then ended up impacting their sense of therapeutic alliance and their sense that their healthcare outcomes were improving. There was another study that was done out of the VA at the University of Minnesota in a program called the Value LIC. And so the students here, they would develop a cohort of 15 to 30 patients approximately. Our students are asked to develop a cohort of about 15 patients. And they took a look at a given PCP's patient panel, and they did a kind of cohort control study, essentially. So they took the patients who were in the student panel, and then they took another selection from that same PCP's panel who were matched for disease severity and age. And they reached out via mixed methods telephone survey. They had a pretty high response rate, higher actually for the value patients or the LIC patients than for the control patients. And what they found was that compared to the control patients who were not working with a LIC student, they were just working with the PCP. And remember, the PCP here is also the LIC student's preceptor for the patients who were in the value arm of the study. The LIC patients had greater satisfaction with the explanations provided by their PCP, greater satisfaction with the provider's knowledge of their personal history, and greater agreement that the provider was looking out for their best interests. And they were more likely to select top box values from patient satisfaction with their overall healthcare. So look something like this. I bet a lot of you recognize those questions on the left as questions that you may get on a dashboard or something else that, that your health system feeds back to you. What I think is really cool here is, and there's some different hypotheses around why this is, but the cool thing is that when the student was involved, not only did the patients have nice things to say about the students, and I'll show you that list next, but they're actually ranking their their primary care physician in more positive ways. So one of the theories here is because of the positive experience that they're having with the student and how that reflects back on the preceptor. And another theory is around the ways that the preceptor may be spending extra time in the room or changing the ways that they explain things when they have a learner who's also present in the room. But I think this is pretty compelling data that our patients who are part of these LIC panels are also having a positive experience. And there is a slew of really positive comments on the right here when they got into the qualitative analysis. But the main themes were that they felt that the students were providing compassionate and genuine care, that it was improving the communication between the patient and their primary provider to have the student involved, that the students were demonstrating a lot of knowledge about the patient and their condition, were thorough and were eager to learn, and that they were excited to be a part of that learning. So that leads me to sort of a parting question for you. And we're not going to break into a small group today because I know it's Friday and we're pushing the end of lunch hour. But I just hope that you'll leave reflecting a little on what you could do to facilitate student-patient relationships in whatever context you play in the LIC. And then also, how can you coach your student to foster continuity and ownership of their LIC panel patients? Our take-home points is that the LIC Patient Panel experience is integral to the LIC. Learning in the LIC activates when preceptors empower students to follow their patients longitudinally, and that patients report positive experiences participating in LIC panels, and that we hope you'll commit to strategies that you're going to try in your own clinical setting, whatever that might be, to support your students' LIC Patient Panel. And I am going to finish with a short video. This is actually Alyssa's preceptor telling us about some experiences that she had participating as a student when she was in the LIC.
I think one of the greatest benefits to having an LIC student is that learner is with you for the course of that academic year. It's not as if you have a learner that comes in and out, you don't really get to know. With the LIC, I feel like you get to really bond with your student. You get to know what their interests are, their passions are, and you also really get to see their growth. I think one of my favorite things too is if I gave feedback on something, she had the opportunity to really enact those changes in real time, and I could see that growth. So that's a really satisfying piece of the LIC, is watching a student grow, really come into their own. One of my continuity patients when I was in the LIC commented that my white coat was growing, and I really loved that because I could see that with my LIC students this year. I feel like that white coat grew a little bit, and I can't take all of that on myself, but hoping to contribute a little bit along the way is a pretty cool thing.
So that's Dr. Stacy Romero-Wilson. She's part of our pediatrics precepting team down here in Colorado Springs, and she participated in the Denver Health LIC a decade ago. So she's able to speak to it both from a student and learner perspective. But I hope that image sticks with you of how you help your students' white coat grow, and the way that our experiences in the patient panel are one way that the students really have an opportunity to take an active role and move into that more empowered student clinician role. Do we have any questions? As we're parting, I'm just going to point out one more faculty development resource that we have available to you. So this is licguide.org, and it's a CU-developed LIC faculty development guidebook that has feedback from lessons learned as preceptors in the LIC. And then as a reminder to put it on your calendar to be on the lookout in the second week of July for your tickler to get your CMA credit from the CME office. And Matt and Alyssa and Nikita, thank you very much for joining today and sharing your stories.